Welcome to the Alfi Podcast, episode 16 with our special guest, Dr. Amanda Vanderstelt. Did I say that right?
Yep.
Amanda, thanks for visiting. Amanda's here from Denver, Colorado, and I'm very excited to have her here because she is one of very few people I would call an airway orthodontist or airway-focused orthodontist. Is that fair to say?
Absolutely. Yeah.
And being an airway-focused orthodontist means that you treatment plan a lot of jaw surgery cases in your practice, right?
Yeah. I do a lot of jaw surgery setups with orthodontics.
So Amanda, how long have you been in practice? I know the answer to this, but...
Yeah, so I've been practicing for 11 years.
Mm-hmm.
And I just opened my practice, though, in Denver a little over a year ago, to have an airway focus and really do things high touch, high quality.
Yeah.
And it's been great.
That's
been
great.
Amazing.
We need more people like you in this field. When did you make that realization or transition to doing more surgical cases, focusing more on airway? Because I know that none of us really learned this in dental school or training.
Well, 7 years ago, I partnered with a general dental group,
Mm-hmm.
and it started out that we were mostly adult patients. So I started doing a lot more quantity of jaw surgery setups about that time.
Mm-hmm.
And everybody wanted Invisalign. So I created my own system to really set up for jaw surgery with Invisalign. I was just seeing so many complex cases, and the more I camouflaged, the more I wished that their jaws were in the right place. And I'll speak for myself, but we're trained, I was trained to really just get the teeth into class 1 and fit together. And
Mm-hmm.
you do that. I mean, of course, we learned about jaw surgery, and there are gray areas where you can camouflage a lot, especially the younger the patient, the more the dental alveolar bone bends with the teeth. But I was seeing a lot of patients in their 50s and even 60s. And by that time, they already have the damage. They already have the recession, cracked teeth, chipped teeth. And from the get-go, 7 years ago, I was practicing where every single patient, child or adult, got an airway questionnaire. And I was looking at Mallampati's. I was looking at tongue function.
Right.
I was looking at their airway questionnaire. And although I didn't have the whole holistic picture that I have now, I would say, I was looking at it, and you can't help but see connections when you have a 50-year-old patient. They're tongue-tied. They have a narrow maxilla.
Right.
They had ortho, and their teeth on the lower were rolled in to match a narrow upper jaw. And now they have tons of recession and abfractions.
Right.
And their airway questionnaire is really high.
Yeah.
You can't help but be curious.
Right. And now you can't unsee it. But so
Yeah.
for you, it was really an open mind and paying attention to all these consequences that people developed. And then you couldn't help but notice that their airway questionnaire signified a problem.
Yeah, I think it revealed a symptom of something bigger with a root cause, right?
Yeah.
And the other big thing was I worked in a GP practice, and they had a CBCT. So
Yeah.
I would actually take, at that point, we didn't have a full head CBCT, but it was enough that I could capture the nasal passageway. And when you look at them routinely and you're curious, like you said, I think that's the big thing is when you're curious and you have that personality that you don't just accept the status quo or just accept
Exactly.
this is how it's always been and I'm just going to keep doing this. When something's like triggering your curiosity that I need to get to the bottom of this, I need to understand why, especially with these older adults that all had these similar connecting, connections.
Yeah.
I couldn't help but want to dig further.
I agree. I think that's a big difference between, I live in this bubble of a lot of the providers I work with are airway focused, but I think that what's common for all of that group is that they don't accept status quo. They're always questioning and paying attention. But this is a minority of providers in the grand scheme of things, because I think most people, especially doctors and dentists, they're really good at learning protocols and following them without questioning. And I don't know if that's a mean thing to say about people in our profession or not, but I do think that as a whole, doctors are, they were good students. They were good at following instruction. They were A students. They performed well reading and duplicating, right? So in order to get to where they are and compete at that level, I feel like it kind of trains that kind of mindset where you're good at doing what you learned to do. And I wonder if that handicaps some of these people, or maybe it's just not their skill set to question.
Well, I think a lot of people spend their whole career trying to be great at what they learn in school.
Right, which is a lot of material.
Whereas especially with airway and airway focus, not just airway, but understanding the whole nasal, the oral nasal system, this system of the head, and how it holistically ties in with gut health, functional health, airway health, and the bigger grand scheme of things. We don't learn that in school. And I don't think, from talking to a lot of my medical colleagues, I don't think that they do either.
No.
It takes a much more, you basically have to relearn an entire system and continue learning it.
Yeah.
Your entire career.
Yeah, I think in the medical system here, there was a wall between dentistry and medicine. I did both dental school and medical school. And in dental school, it's like you really focus on the teeth and getting, cavity-free teeth, restore cavities, disease-free teeth, straighten them, and put the bite together, right? But when you're doing that, you're ignoring everything else. Like you said, the gut, breathing, airway, every other system that's tied to the mouth. And then in medical school, we learned all the other stuff. The gut, the bloodstream, all these conditions and how they relate to each other. But when it came to teeth, there was a hard stop there and said, oh no, that's for the dentists. Right. And it was interesting being in both those schools. It's like, in med school, they just stopped, TMJ, that's for dentist, teeth, that's for dentist. But the reality is, like, it's part of the body. And not only is it part of the body, but the mouth is maybe one of the most important parts of the body. If you think about priorities, breathing and eating and speaking, and what that does for the system. But now you have a medical system that separates the two. And I think that probably is causing a problem.
Yeah, I would agree. Yeah. I think that there are a lot of bridges that need to be, a lot of bridges that need to be developed between medicine and dental. I met with an ENT who's a head of sleep medicine in Denver somewhere, and we were chatting about this. And she said that when she graduated from her fellowship after ENT, she was one of 6 people in the country, and I think that was like 12 years ago, one of 6 people who had done ENT and then done the fellowship for sleep medicine, which is interesting because ENT involves, part of the one of the most important areas of the airway, the beginning of the airway.
Yeah, absolutely. And then there's a huge disconnect there because, you think about ENT residents, how many of them still learn anything about the mouth or the teeth or the jaw sizes or the bite or the anatomy as it relates to the upper airway, except for the nose and sinuses, right? Yeah. It's like they're focused on identifying nasal issues, sinus issues, and then their treatment algorithm is only those things, right? Fix the turbinates, fix the septum, but it's not even really in their wheelhouse unless somehow they were immersed in an orthognathic program to understand what jaw surgery can do. So it's even in that subspecialty, that niche of airway, sleep, medicine, ENTs, there's still probably a big lack of awareness of a huge underlying root cause or problem, which is jaw size.
I think you nailed it. And it's actually refreshing to hear that because I don't talk to a lot of people. Because, you talk to an ENT who is the head of a sleep clinic and they're talking about, well, everybody starts with a CPAP and that's great. Or they get an oral appliance, which, if you don't know, an oral appliance that positions your lower jaw forward, it can give you some temporary relief by opening up your airway, but it changes your bite.
Totally.
There is not an oral appliance that does not either change your bite by moving teeth and or by muscularly moving the jaws forward.
Right. Or changing the joint anatomy.
Or changing the joint. And so, I think like in talking to these people, it's like, well, do you ever talk about jaw surgery as a potential actual fix of the root cause? And I think that they are like surgery is last resort, you know? But like, as I shadowed you today, I mean, jaw surgeries with the right surgeon, the right orthodontist, the right team, interdisciplinary team, can go very smoothly and be life-changing permanently for the patient that really is a good candidate.
Yeah. And it could avoid so many other procedures that won't even really get that impact. Right. But I think what you're saying is key. It's got to be the right providers. Let's talk about that, because I really think, I know a lot of orthodontists. I work with people from all over the country, even other parts of the world, and not all orthodontists are created equal. I think that most orthodontists are really focused on the teeth level and the bite and still don't really understand airway, or maybe even have some denial about how the teeth are related to the airway. I think that as an ortho community, organized ortho community, there is a block there. But there's a growing number of airway-focused orthodontists like yourself. So if you're in Denver, for instance, definitely check out Amanda. But they're rare, right?
Yeah.
So, I would say, what would you say? How do you look for an orthodontist like you? What are the things that you're looking for?
I mean, I think obviously it's hard to know every nuance of how someone practices, but the bare basics are you can always Google airway-focused orthodontist, start there. Secondly, I think that when you meet an orthodontist, I mean, I'm one of very, very few orthodontists in Denver who has a CBCT, that's a 3D x-ray. You can't really holistically understand airway and jaw structure if you don't have a 3D x-ray. Yeah,
that's crazy to me that that's not standard yet.
When I was doing my build out, I mean, it's the way that even doing an orthodontic startup practice works is there was not enough money allotted from the bank for me to afford a 3D x-ray. If I had to pay for it out of pocket pretty much. And so I can understand that if you're younger, you're out for 2 or 3 years and maybe you're thinking about finances as you're opening a practice, or you buy an existing practice and you don't have extra money to put a CBCT in there, not to mention the workflow. You're also liable for, any pathology that you may come across. I think there's a lot of workflow issues with a 3D x-ray. And then even if you buy an old practice, do you have the space for it?
Right.
So I think that alone.
So there's some barriers to even having a.
Yeah, that alone though is something. But for me, I had hired a consultant originally, and they're like, "Oh, don't get the 3D X-ray." I was like, once you start practicing with the 3D X-ray, and you desire to really practice comprehensively, you can't not practice with one.
I agree, 100%.
You can't unsee it. So I would say, I think I'm the only one in Denver, that practices where I take a CBCT x-ray on every consultation.
Yeah.
And we have a really low dose, version for young kids so that we can get information, but it's very, very low dose. So I feel it's safe.
Yeah,
I do it on my own children to evaluate.
Yeah, and one 3D film gives you all the views. Instead of taking a Panorex, a lateral ceph, some dental films, that one film captures it all. You get 3D representation, you get CT slices, the lateral ceph, frontal, PA.
Also the airway questionnaire.
The airway questionnaire. You get so much in there.
Every person who comes to my practice gets an airway questionnaire, child or adult.
Yeah,
and
I think that's a big one. Your orthodontist should be asking about the airway. And if they're not, that I think that's a red flag.
Yeah.
Right?
Yeah.
As cone beam CT, I think that's a good clue, because you can't really be airway focused if you're not looking at 3D films.
It's hard. I mean, you can try, but you're just missing.
Yeah.
You're just missing pieces. So
How about phase 1 ortho? Because I know not all orthodontists do phase 1 orthos. Is that true?
Yeah, and I don't know if that's regionally different, but in Denver, definitely the majority are not doing it comprehensively. What I found is that a lot of orthos who do phase 1s are mostly just doing
before
the
you
upper
get
arch.
into that.
Yeah.
What is phase 1 to the public?
Oh, yeah. So phase 1 is just, it's early intervention orthodontically with a child who is probably between the ages of 4 to 10, pretty much. Maybe they have all their baby teeth, or they have mixed dentition, meaning they have mostly baby teeth and some adult teeth. But the whole concept of a phase 1 is it's early intervention to really get the jaw structure, or it could just be teeth, but it's usually jaw structure related, to try to normalize or idealize a jaw structure that is growing on the wrong trajectory.
Right.
Plus,
which is very common.
Any oral habits additionally.
Most kids are dealing with these issues.
Yeah.
And it's such a huge opportunity at these ages to help the kid grow and develop their jaws, not only to minimize how much ortho or jaw surgery they may need in the future, but if they're breathing better at that age, forget the teeth and the jaws and the beautiful faces, just the brain development, the growth hormone secretion from a good night's rest, so critical. And really, if you think about that, like how important are orthodontists who do phase 1 ortho for health and wellness in our communities and the potential for these kids to develop? I really think that it's huge.
I agree.
So why do you think, I feel like a lot of orthodontists don't do this. They say wait for permanent teeth to come in, right? Even if the canines are impacted, they don't have room there. Wait till the permanent teeth come in so we can anchor them and put them in there. But really, it's such an opportunity to expand that bone and make room for these canines, for example, to come in. So why isn't it ubiquitous in ortho?
I mean, it's hard for me to answer that because I don't practice that way. I look at things so much differently. I think I look at the bigger picture, but that's part of that is also because I had my own airway issues, and not just my own airway issues, but then when I practice, like I said, in that general dental practice where I started off seeing a lot of complex older adult patients, you think, gosh, how could I have why is your mouth so damaged? How could this have been prevented?
Right.
And again, I'm a very curious person, and I think, okay, well, if this would have happened, early on where we developed the maxilla. Perfect case example, I think, is we see so much recession these days. And with recession, you wonder, well, why do we have recession? So many hygienists out there, and people are telling patients that they have recession because they're brushing too hard.
Isn't that
How
ridiculous?
many times have we... It's ridiculous, but there are dentists, even the doctors are still telling patients that. And even some periodontists still tell patients that.
Yeah, think about that.
I see it all the time.
It's like your hygiene is so good. You brush too much. Your hygiene is so good that you're causing recession.
Which maybe it could exacerbate existing recession.
Yeah, I don't even think so.
But when you look at it and you really understand, you have to have quality bone and quality gum tissue.
Right.
And that all starts with how the jaws developed and where did the teeth, what direction did they come in?
Yep.
And so many times it's like, okay, well, just let the upper canines come in way out. Well, they're going to have thin bone and thin gum tissue.
And that's where you're going to get recession. And
or these lower canines,
the trauma,
too.
if you're grinding your teeth and clenching your teeth every night because you want to keep your airway open, you're going to cause trauma on those ligaments, the bone, and cause recession.
It's a perfect storm.
It's a perfect storm. And then your tongue is pushing the teeth out. The muscles in your mouth and lips are putting pressures from the outside, and these things are causing recession. Makes way more sense to me. Have recession because you're brushing too hard. That's a myth.
Yeah.
I'm gonna bust that one.
Bust it.
I think that's false. I'm gonna go with most recession in people that have good hygiene is all airway related. And it's a huge sign of airway problems. You know what's interesting? For those of you who have been diagnosed with gum recession or generalized recession of your gums, what did that same dentist that says you're brushing too hard prescribe to you as a solution? A deep cleaning, right? So then they take metal and hard instruments and really go to town as a treatment. So that makes no sense to me too. If you're saying you're brushing too hard with the bristled brush, but to fix that, I'm going to take metal and scrape on those teeth and gums with something much harder.
Or, gingival grafts too. So, I mean, they're grafting, but
Right.
how many times do we see patients who had grafts and you look at them come back and you're like, you had that grafted? It looks exactly the same.
Right.
Why?
Mm-hmm.
Because they didn't look at the bigger holistic picture
the
of
root cause wasn't
what's
solved.
the root cause.
Yeah.
Grinding, maybe there's poor angulation, the way that the teeth are hitting.
Right. What caused that recession in the first place? And just putting that gum tissue right back there and not addressing what caused that gum recession, same thing is going to happen to those teeth. I really think that's the same thing for all of dentistry, right? Like we get patients in general dentistry or when we're in dental school, you get everything you see. You have cavities or teeth with cavities, right? The solution is just to fill those cavities. But what's going to happen over time? Whatever created those cavities is still going to come back and destroy whatever you put in. You have traumatic forces on the teeth and you start breaking your teeth down. So then you put crowns on these teeth, you restore them back to their health. But again, what happens if you don't take away the reason that caused these teeth to break down? Same thing's going to happen. Then you have missing teeth, and our go-to is let's replace those missing teeth with a bridge or implant. Again, never addressing why those teeth were missing or lost in the first place, and then people lose their bridges or implants or root canal teeth, whatever it is. But I feel like every aspect of dentistry, the way we learn it, it's like there's a problem, fix it, but that problem is still there. So it's not really fixed. Everything's just being patched up. It's interesting.
Yeah. I think my analogy is, if you have someone who builds a house and they don't know anything about the foundation, meaning the jaws and the airway, then they build the house and there's a crack. And the crack develops and they keep repairing it and patching it. And the crack keeps developing and getting bigger and bigger. And they're like, well, why? Okay, I'll just repair it. If you never understand the foundation that you're building, then how are you going to ever truly fix it? You're going to keep repairing it over and over. And that's what happens in dentistry.
Keep painting over it, repairing. That's exactly what happens in dentistry.
But it's, in all fairness, I mean, I think about my entire career trajectory, and it's not just because I ask why. It's because I also go to endless amount of education. And it's almost like I'm flying back to Texas on Thursday for more education.
And you volunteered today to come to the operating room and see surgery.
I helped so much.
But no, it's a testament to your curiosity and thirst for learning.
Well, I think it's important. We have some mutual patients, and out of respect for my patients, I want to make sure that you and I connect because I believe that the best care for our mutual patients is to have a cohesive relationship, to be on the same page and to be able to bridge, our fields and to be able, even though we're a flight away, to be able to understand what you're thinking and what I'm thinking. I think it's so important because a phone call doesn't do it justice.
No. Yeah. And it's so important to have a good unified team. Because it takes more than just surgery. It takes more than just ortho. It takes more than surgery and ortho. And we talked about myofunctional therapy. I talk about it a lot and how important it is. You told me that you have a myofunctional therapist in your practice.
Yeah.
Which I think is fantastic.
It's a whole system, right? And your tongue is such a powerful piece of this. And the tongue doesn't always function right. It doesn't always grow and develop correctly. It's another piece of the bigger puzzle. And it can also cause, if you don't address it, it can it can cause further relapse, other problems. It can, it's just one very important piece.
Yeah, absolutely.
So
I think that's true. And, we never really focused on the tongue in school or residency, but I agree with you. I think it's such an important piece of the puzzle. It has to function appropriately for anything in the mouth to work out right. For the teeth to develop appropriately. I mean, it's the best expander we have is a good functioning tongue.
Early on.
Yeah.
But I think there is also a lot of misunderstanding. I think one of the things that has happened with orthodontists is, like you, orthodontists and surgeons and high quality providers, doctors are very evidence-based, especially specialists.
Yeah.
And there has been a lot of, kind of, I guess, postulation of different providers who are not doctors that or even companies that push different agendas that aren't evidence-based, like different products, for instance, or different theories that the tongue can fix everything. And, you have an 8-year-old kid who's severely narrow that you do myofunctional therapy and can just magically fix the jaw. And that's incorrect. It's not evidence-based.
Right. Yeah. It's not just one thing. You can't do one thing and expect everything to work out. But you got to kind of do everything right. Have to they have to find someone in their team that can offer jaw surgery in a predictable, stable fashion, for one. And unfortunately, that's not easy to find. They don't exist in a lot of places. I think that will change as technology is making jaw surgery a lot easier. But it's true. But it's not that they don't exist. I think the orthodontists just have to find the capable people out there. Otherwise, they're not going to be able to offer these things.
What do you think how would you describe a quality jaw surgeon?
I think, it's a great question. It's a very difficult operation.
Is that the same surgeon placing implants?
Correct. It's a difficult operation in the sense that there's so many things that you need to pay attention to and do well. And there are things that are, every patient is different. There are muscles at play. There are teeth at play. There's healing at play. And technically, it's not an easy operation. So, if a surgeon is spending most of his time taking out teeth, putting implants, doing day-to-day routine oral surgery, and then once a month is doing jaw surgery or twice a month, it's impossible he's going to be as good at it. I think jaw surgery is one of those operations where if you're looking for a surgeon, you want someone that's pretty much all he does. He at least, or she, he or she, you want a jaw surgeon that spends 90% or more of their practice doing jaw surgery, who's in the operating room 4 times a week doing jaw surgery, has it takes a team too. So has the resources and the team and the system at place where he can not only be in the operating room, but, plan the cases, talk to orthodontists. There's a lot that goes into doing these cases appropriately, but in order to do that, you really that has to be the primary focus of that practice. And there are very few surgeons out there that's pretty much all they do. But those are the ones you want to look for. And then on top of that, you want someone that's up with technology because things have changed. They're so much better than they used to be. You saw today, it's a completely different operation. So, if one, they got to do it all the time. 2, they got to be up to date. Up to date nowadays means custom titanium printed patient specific plates and screws. I should say plates and virtual surgical planning. So you want it to be up to date. They should be multidisciplinary, which means that they're working with orthodontists, myofunctional therapists, periodontists. They have a team approach. It's not just one-stop shop. And then the other piece of that, let's see, there was one more that I had in mind. I don't know. What else am I missing there?
The functional? Were you going to talk about that?
Oh, airway.
Yeah.
Airway. They should be airway focused because, you know, the real root foundation of jaw problems is that it affects airway. And if the surgeon is just putting the bites together, even if that's all he does 100% of the time, and he's up to date, but he's not focused on airway, you're not going to get the results that you want. And then over time, the soft tissue and function is going to ruin those results or outcomes. So, yeah, I think volume, that has to be all that they do. They have to have the systems in place to do that, multidisciplinary, up to date, and focused on airway.
Yeah. Yeah, I would agree with that. I think that's a great answer. And there aren't many of you all. That's the hard thing for orthodontists to find.
Yeah, but here we are talking about this stuff. I think that there are surgeons out there and residents and students that are paying attention. And I do see it making a difference. And hopefully for the orthodontists too. I hope there are a lot of orthodontists tuning in. Remember, subscribe, like, follow. Send this to your orthodontist. Send it to your dentist. Send it to your surgeon. Because at least they should be listening to this conversation. And I think that'll go a long way and make this world a better place if you're sharing this information.
Well, thanks for having me. I really appreciate it. And it's pretty amazing to see your focus in surgery and how streamlined your processes are. It was incredible.
Cool.
And how airway focused you are and, you know, holistically you practice.
Yeah, I appreciate that. It's a pleasure hosting you here.
Thank you.
Final question before we wrap it up. Greatest basketball player of all time?
Michael Jordan.
There you go. It's a great answer. Great answer. MJ the GOAT. Comment below. Let me know who you think it is.